we can examine the electrical activity of the heart using a clinical instrument or a technique known as an electrocardiography or an electrocardiogram. These are also known as ECGs or EKGs, which is probably more familiar to you guys. As a side note, often this is referred to as EKGs, and that's because in Europe, cardio is spelled with a K as opposed to a C. And so what an electrocardiogram is it's basically a composite of all the action potentials in the heart. So the action potential of our 1%, our pacemaker population, the action potential of our contractile population, and basically it shows you that electrical activity as a single readout. Now, in a true ECG, they do something called a 12 lead, which gives you a whole bunch of images on a screen that you can interpret from different aspects of the heart. This image here represents something called a 3 lead. And the 3 lead is your traditional kind of ECG profile that's often referred to. And I first need to tell you that this is not an action potential profile like we've just gone over that shows an individual cells. You have to remember that this is the entire electrical image of the heart, okay? So the movement, like the upward movement does not necessarily, on an ECG, does not imply a depolarization event, necessarily, okay? So, in our ECG, we have kind of 3 characteristic waves. We have a P wave, which just occurs right here. We have a QRS complex here, and we have a T wave here, okay? So our P wave represents the depolarization of our SA node, and that actual depolarization of our SA node actually kind of occurs right here. Okay, because the P wave actually represents atrial depolarization. So in order from the atrium to depolarize, our SA node had to have fired prior to that depolarization. So typically your SA node will depolarize here, causing the depolarization of your atrium. Okay, now our QRS complex represents 2 events. One, ventricular depolarization, and again, okay, this means that if this represents our ventricles depolarizing, okay, then that means our AV node had to have fired prior to this event occurring, okay? Now, the reason you don't see the AV node and the SA node in this signal is because there's such a small population, such a small electrical signal in comparison to the enormity of the heart itself, okay? So we have ventricular depolarization, but also in this profile, we also have atrial repolarization. So both of those events occur in this window of the QRS complex. And then we have our T wave, and our T wave represents ventricular repolarization. Okay. Now again, this goes back to that notion, right? This is an upward wave, right? But it goes against what we normally know as a repolarization, which is a downward. Okay, and again, that's because this is not like a single cell action potential profile that we looked at before. Okay, so when we look at these depolarization and polarization events that occur in this wave, okay, or in this ECG, what we can see is the following. Here is our SA node, okay, and again, we know our SA node kind of has to occur right here. Okay, so our SA node fires. This causes that depolarization of the atrium. We see that here in our P wave. Okay. Our AV node, right, that depolarization travels across the atrium and basically activates our AV node. So here is our AV node depolarization, okay, which we see here. Okay. That depolarization travels down our sinoatrial node, or down our bundle of His, down our right and left bundle branches, okay? And we see that here as this goes down, right? We get this big QRS complex. In addition to that, not only do we see this depolarization event, we see this repolarization of the atrium, Okay, so again, this QRS complex represents both events here. Depolarization of the ventricle, repolarization of the atrium. Okay, now that depolarization spreads up through the Purkinje fibers. This typically occurs in that ST complex or ST interval. Okay, and then we get repolarization of the ventricles, which is represented here by our T wave, and we go back to resetting and we start the whole system over again. When we look at an ECG on a tracing, okay, so again, this is that ECG. So here is our P, here is our Q, R, S, and T, and here's our next P. So it's a little bit more difficult when you have them subsequently one after another, right? Okay, so this is a normal sinus rhythm, right? It says right here, normal, okay? Now we have a junctional rhythm. Okay, so in a junctional rhythm, right, our SA node is absent or non-functional. And how that presents or how that is seen on an ECG, right, if we look at this profile here, we can see, right, that P wave that occurs prior to the QRST is missing, right? So that automatically tells us that our SA node is not functioning. Pretty cool, huh? Okay, let's come down and look at our next one, right? So here's our P here, we have our Q, R, S, and our T, and we have a P. Uh-oh, what are we missing here? And here. And here. Right, we're missing our QRS. So what that means is, right, our SA node's firing just fine, because here's our P wave. However, remember that our AV node is the only way the ventricles can acquire its depolarization. That's the only way to get to the ventricles is through that AV node. Okay, so this would be a partial heart block, right? They call it a secondary heart block because we are getting some, right? We can see here we are getting some contractions or some electrical events down through the ventricles, but not with every AV or SA node depolarization event. Our last one is ventricular fibrillation. This is also referred to shorthand as VFib. Okay, there is no deciphering anything on this. This is where you'd go out and you'd get a defibrillator and you'd put the patches on the individual and you'd hit the button and they would electrocute or shock the chest in hopes of reestablishing the rhythm of the heart. When we look at the heart sounds, okay, so if you ever put your head on the chest of somebody and you're kind of laying there, falling half asleep, oftentimes you'll hear the heart going lub-dub, 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 okay? And the sound of the heart actually comes from the closing of those valves. So the first sound, the lub, okay, this is due to the AV valves closing. The dub is due to the semilunar valves closing. Okay, so remember our AV valves are the bicuspid and tricuspid. The semilunar valves are the aortic and pulmonary valves. Okay, and these words here, right? Systole means contraction. Diastole means relaxation. Okay, so again, our heart contracts, the SA or the AV valves close, there's our lub, okay? Ejects out of the aortic and the semilunar valves, the aortic and the pulmonary valves. Our heart relaxes, goes into diastole, and the semilunar valves close. And then we have a pause, right? Lub-dub, pause, lub-dub, pause. That pause is where the ventricles are refilling. Okay. So if a patient has a heart murmur, this is typically an abnormal sound. It's usually due to either, typically indicates an incompetent or stenotic valve. We talked about those in the previous video. Oops, wrong way. So looking at the mechanical events of the heart, okay, this is known as the cardiac cycle. And the cardiac cycle is basically the blood flow through the heart during one complete heartbeat. And it is essentially an atrial systole, which again is contraction, followed by diastole of the atrium, which was relaxation. This is then followed by ventricular systole and ventricular diastole. Now, this is a circular event, right? So heartbeats are a circular event, right? It's just a circle. So we have to designate somewhere as step one. Okay? So this looks like a really complicated figure, but it is probably one of my most favorite figures in terms of, although it's super complex, it shows everything on top of each other, and it's so beautiful. So let me see if I can explain this to you guys, and you guys find the beauty in it afterwards too. Okay? So we have ventricular filling. I don't even want you to look at this image. I just want you for a second to think about the following. If our ventricles are filling, okay, where is that blood coming from? Coming from the atriums, right? Okay. So if it's coming, so if our ventricles are filling, the blood's coming from the atriums. What do our AV valves have to be? Open or closed, right? If we're going, blood's flowing from the atrium down to the ventricle, is our AV valve open or closed? It's open, right? What about our semilunar valves? Is blood coming back down into the heart? No, remember, our heart's still relaxed. It's filling. The ventricles are filling, right? So our AV valve, our SL valves are closed, right? Okay. So we just learned a whole bunch, right? So we just essentially just covered this first area. Ventricle filling, our AV valves right here are open. Our semilunar valves are closed, okay? Now, what's going to happen, right, is this blood that's entering the ventricle, 80% of it is going to enter passively. Just gravity is going to pull it down, okay? And what's going to happen is, to get that last 20% out, you're going to cause those atriums to contract. So that means towards the end of our ventricle filling stage, we're going to trigger the SA node to fire, causing the depolarization of our atrium and contraction of our atrium. Right? Again, we're still filling, right? So everything's still open. So in ventricle filling, we have ventricle filling, and we have atrial contraction. Again, you guys, if you just take a step back and think about it logically, it makes sense, right? If the atrium are filling the ventricles, that means the AV valves have to be open. The ventricle's relaxed, so that means that the semilunar valves are closed. Okay. Well, I need to get the extra amount of blood that can't get down there via gravity out, so I need the atrium to contract. So that means I have to activate my SA valve to get the contractile cells of the atrium to depolarize, which then results in the contraction of the cells, and now we get atrial contraction. Oh my God, so excited, right? Okay. Our second step is ventricular systole, right? Ventricular contraction, right? That makes sense. Our ventricles are full, okay? So now again, don't look at the picture. Let's just think about this, okay? So our ventricles start to contract, right? So if this is my heart, ventricles start to contract, okay? Now, remember, this is a closed circuit, okay? So as that ventricle starts to squeeze in, right, we're going to generate pressure inside those ventricles, right? So as that heart contracts, we're going to snap those AV valves closed. Right here. Boop. Closed. Okay? So our AV valves are closed, but there's a period in time in which the pressure inside the ventricles is not greater than the pressure in the great vessels. So it's actually not quite strong enough. We don't have quite enough pressure to overcome the pressure in the aorta or the pressure in the pulmonary trunk. So there's a short period of time where not only does the pressure inside the heart close our AV valves, but the pressure inside the heart isn't great enough to overcome the pressure in our semilunar valves. So in this case, it's a completely closed chamber, okay? And this is called isovolumetric contraction phase. Okay? Iso means same, which means everything's closed. Okay? However, in this ventricle systole phase, okay, as that heart continues to contract, okay, eventually the pressure inside of this ventricle will overcome the pressure inside of the vessels and blood will eject out, called the ventricular ejection phase. Okay, so let's think about this for a second. Don't even look at the image, okay? So if my ventricles, the pressure of that blood inside my ventricles is great enough, right, to overcome the pressure in the vessels, okay, that means, again, remember, my AV valves are still closed, right? We don't want regurgitation up into the atrium. We want to direct that blood out the vessels, okay? So that means at some point, the pressure inside the heart becomes greater than the vessel, right? And we eject that blood. Well, okay, well that means our AV valves are still closed, and that now means our SL valves are now open, okay? So we eject blood out of the ventricles, okay, and into our vessels. We're not going to follow that because we're talking about cardiac cycle. Okay? Okay. On to our last phase. And this is called isovolumetric relaxation. Okay? So the heart just contracted, squeezed all the blood out, and now it's like, oh, I get to open up again. Okay? And when it does this, because I get to relax, not open up again. I just get to relax. Okay, that means the semilunar valves close. Right, we don't want that blood coming down from the vessels that just went up there. Okay, however, the pressure in the atrium isn't quite strong enough to open our AV valves quite yet. So there's a small period of time where the heart just gets to go, oh, there's nothing there. And all of a sudden, next thing you know, the floodgates open, the AV valves open, and you restart ventricle filling. Okay? So, I know your book divides these into 1, 2A, 2B, 3. I really want you to understand these: ventricle filling, atrial contraction, isovolumetric contraction, ventricular ejection, isovolumetric relaxation, and then back to ventricular filling. Okay? Whew. Isn't that exciting? Oh my gosh, so exciting.